Good morning, Dr. Curry.
Good morning.
Can you remind the jury who you are and what you do?
Sure. I'm Dr. Shannon Curry. I'm a clinical and forensic psychologist, and I'm here today to rebut the testimony that was provided by Dr. Hughes.
Which of the opinions rendered by Dr. Hughes do you intend to rebut?
So generally speaking, there are three main categories that I'd like to talk about today. So the first is that Dr. Hughes misrepresented the tests and the results that she utilized in her evaluation. She misrepresented my testing and the results that I obtained in my evaluation. And she communicated in a manner, provided testimony in a manner that presented essentially her own opinions and the self-report of Ms. Heard as facts.
Okay, the first category you talked about was the misrepresentation of her own test methods and results. What do you mean by that?
So Dr. Hughes she stated that she administered 12 tests. In actuality, she used 8 checklists. About half of those were symptom checklists. The other half were checklists about experiences that people can have with domestic violence. And those are not appropriate for forensic settings. They are easily exploited.
Other issues that you intend to address relative to misrepresentation of own results?
Yes, so in addition to using these checklist measures, which are easily exploited in a forensic context, they're developed for research or treatment only. She also stated that these checklists revealed things that they simply cannot reveal, especially in this context. Let's see. She also misrepresented clear indications on several of the objective measures that she offered. And there were indications visible that Ms. Heard had essentially engaged in what we call response distortion. So clear indications of exaggeration on one of the measures that's specific to PTSD, clear minimization of symptoms intentional on another more broad personality and psychopathology-based measure that she gave to Ms. Heard, which she did not acknowledge.
Did you intend to address anything relative to the CAPS-5?
I did. So Dr. Hughes administered the CAPS-5 about 10 days after I did, almost 2 years after she initially tested Ms. Heard, and she did not administer the test appropriately. So she left major components blank. She didn't apply the scoring rules that are clearly outlined with the test, and yet she diagnosed Ms. Heard with PTSD based on that assessment.
What about Dr. Hughes's use of the personality assessment inventory?
So of the tests that Dr. Hughes administered, 2 would be considered. Of those 12, 2 would be considered what we call forensically relevant instruments, meaning that they're objective enough and they provide us with some information about how the examinee approached the test, that it would be appropriate for this setting where the examinee is going to have a natural incentive to present themselves in a way that benefits the outcome of their case. Now, on the PAI, there were clear indications that Ms. Heard was responding and obtained scores in a manner that's consistent with individuals who have a personality disorder. And there was also an indication that several scales, we call this a configuration. So you might have one main scale that you notice is elevated, then you look for additional subscale information to get additional information on what could be elevating that scale. And there was a configuration that showed that even though Ms. Heard had moderately elevated one of the scales that can be associated with trauma, that elevation is better explained by childhood or distant traumatic experiences like the complex trauma Ms. Heard reported experiencing growing up.
Okay. You said that Dr. Hughes utilized checklists that are not appropriate for forensic analysis. Can you explain that?
Yes. So As I said, in any sort of forensic context, whether it's a civil or a criminal matter, a person who's being evaluated is going to have major incentive to present in a way that benefits the outcome of their case. So you always approach the examination, I believe Dr. Hughes said, with a healthy dose of skepticism, but that alone is not enough. We have to operationalize that. So we actually have to administer very comprehensive objective tests that either control for attempts to manipulate the test results or reveal attempts to manipulate the test results, so that we're not just blindly accepting the results or the self-report of the examinee.
How many tests were administered by Dr. Hughes?
She said that she administered 12 tests.
How many of them were appropriate for forensic physical examination?
So the trauma symptom inventory is appropriate. It's an objective measure, and it does have two primary scales that look at how the person approached the test. The personality assessment inventory is an excellent test. It is a broadband measure, meaning that it captures not only symptoms of mental illness, but also general personality traits. That also gives us pretty detailed scales similar to that one test I administered, the MMPI, that tell us a lot of nuanced information about the way the person approached the test. She also administered a malingering screen that can be very, very useful, but not in this context. So it's called the Miller Forensic Assessment Symptom Test. It's a brief set of questions that you ask the examinee, and it's been shown by research to be extremely effective at identifying an examinee's attempts to fake a severe mental illness or psychosis. And psychosis is when somebody loses complete connection with reality. It's excellent for that purpose. It's actually been shown in the research to not be effective at all for identifying a respondent's attempts to fake PTSD, anxiety, or mood disorders. The questions are just too odd for somebody who has the wherewithal to be trying to have PTSD to endorse. They see through it. So she used that. That's a fine test, but not appropriate for this context.
Of the various tests that she administered, how many were these checklists?
8 of them.
All right, and what are you talking about specifically?
Okay. So I had mentioned that there were 2 main categories of checklists she used. The first is the symptom checklists. Those included the Beck Depression Inventory. It's a brief inventory of items that essentially show all of the symptoms of depression that a person might have, and you rate which level of severity you have for each question. She also gave the Beck Anxiety Inventory, very similar, but just with questions about anxiety. She gave the Mood Disorder Questionnaire, which is a very brief, again, checklist. It shows symptoms of bipolar disorder. Bipolar disorder is a mood disorder where you might have an extended manic episode and then a very extended depressive episode. And then she gave the Post-Traumatic Stress Disorder Checklist, and that is a screening instrument only. It contains every single symptom of PTSD. So there's a secondary danger here too. When you think about it, given that PTSD is the most frequently feigned and claimed diagnosis in civil courts, if you're handing somebody a checklist that lists every single symptom of PTSD, you're essentially teaching them all the little nuances that we're looking for to give that diagnosis. So she gave that to Ms. Hurd. Ms. Hurd endorsed most of the items, and Dr. Hughes diagnosed her with PTSD and substantiated that opinion by Ms. Hurd's checking those items on the PCL-5.
Were there another group of checklists that Dr. Hughes used?
Yes, so she also, and I forgot one on the last because I don't think of it as one, but previously I'd explained, and I do not expect you to remember, it's called the Life Events Checklist, which is just an inventory of experiences a person may have gone through that are traumatic. Dr. Hughes also used that, and that's appropriate to use before the clinician-administered PTSD scale, the gold standard CAPS-5. However, she administered this long ago before she gave the CAPS-5. Now that going on to the second group, there were 3 checklists that she gave that are specific to abuse. And the first she gave, the Danger Assessment Scale, was actually developed for use by nursing staff in an emergency room setting, specifically for female victims of intimate partner violence. The purpose of this is important because our forensic ethics, our psychology ethics, talk a lot about relevance. Is the test relevant to the purpose? And the Danger Assessment Scale, its initial purpose was completely different. This was developed to show high risk factors for dangerousness and pretty much to help a female who is in an extremely abusive partnership, who is in the emergency room with extreme injuries, to stop rationalizing, because if she has to check off all the things that have happened that year that have been dangerous, does he own a gun, has he, I won't go into all of them, but the more she checks off, the more likely it is that she might realize that she is in imminent danger, and then accept resources offered by the hospital and social work to protect her. That was the purpose of this scale. It was never intended to be used as a retrospective measure to look back in time and find out whether abuse was occurring based on one person's report years later in a litigation. She also gave the Conflict Tactics Scale, revised, the second edition. Similarly, this scale was developed for research purposes, to research family violence. Again, there is no control for exaggeration or minimizing. It was just given to research participants anonymously so that we could get data on the prevalence of abuse and how abusive dynamics work. And on that, there's 39 questions where the respondent indicates essentially certain abusive behaviors they may have engaged in, and then 39 where they indicate behaviors their partner might have engaged in. And obviously, you can understand that in a forensic setting, the respondent is likely to put a very minimal amount of behaviors they engaged in, and then extremely increase the number of behaviors their partner might have. And then lastly, let's see, the abusive behaviors observation checklist was the third checklist she gave. This one has not, there's no known research even on its effectiveness for what it was developed. It's a theoretical, very brief checklist that was meant to be used for therapy, where an individual who had experienced domestic violence could essentially read through some of the behaviors that constitute violence that they might not have been aware of. And if those behaviors applied to them, or if some of those coping strategies were ones they utilized, they would check that off, and then they have a way to talk about it because now it's been put to words. Again, this is similarly problematic if you're in a civil litigation, the person's motivated to have their results be consistent with a claim or an allegation of intimate partner violence and an allegation that they've been severely harmed, then they could simply just check off more. And not only that, but checklists like this one specifically give a lot of nuanced information about what clinicians might be looking for when they're assessing whether violence was present or whether the person's self-report is consistent with a genuine self-report of having been victimized. They're given all that information that we might be looking for.
Can you talk specifically about Dr. Hughes's use of I think you called it the PCL-5?
Yes. So the PCL-5 is the post-traumatic stress disorder checklist. This is different, not to be confused with the CAPS-5, which I've talked about previously as being the gold standard. The PCL-5 was developed by the National Center of PTSD. It's intended for treatment. So if I were, for instance, working with a service member who I know had been in combat, I would probably give this as a standard with my intake. Before we do the diagnostic interview, it kind of gives me a read on how somebody who's there for treatment, who we assume can be taken at their word because if they give us correct information, they're going to get an appropriate treatment. And if they give us incorrect, they might not get the treatment they need. So I would give this checklist to them, and then if they recognize some of those symptoms of PTSD, they could check it off. And that would probably indicate to me that I need to then do the next step. If they're checking off more items than not, I would probably decide to administer the clinician-administered PTSD scale, that gold standard interview, to find out more about a diagnosis.
The last thing is what everybody refers to as the CAPS-5.
Yes, the CAPS-5.
All right. What about, well, you talked about forensic use. What do you mean by that?
So when I'm talking about forensic evaluation, that's an evaluation that isn't done for therapy or treatment. It's specifically to assist the fact finder, to assist the judge or the jury in the court by providing information about the psychological status about an individual. And that's an important delineation too. We are not psychologists. I wish we were mind readers. I wish we had a crystal ball and could find out whether intimate partner violence occurred and look back in the past. But it's nothing like that. Really, it's a lot less interesting. We look at data. We have to control for those response biases. And then we also are looking at functioning, which is really the bottom line of the assessment. Did the person have a change in functioning from before the alleged trauma, or in this case, the alleged IPV, to after? Is there a decline in the way they're going about their lives?
Objection, Your Honor. May we approach?
All right.